Good afternoon, everyone. Thank you very much for joining our webinar today. Nancy Merriman, I'm going to hand it to you to get us started.
All right, great. Thanks, Heidi. And thanks, everybody, for joining us today for this discussion about the Alaska Health Information Exchange, or HIE, and the Alaska eHealth Network. Next slide, please. During the next 90 minutes or so, a couple of us will be sharing information and updates about the Alaska Health Information Exchange and the work that AeHN is doing. But first, allow me to introduce the speakers for today. I am Nancy Merriman. I was elected to serve as the president of the Alaska eHealth Network Board of Directors in January of 2017. I'm also the executive director of the Alaska Primary Care Association. Heidi Wayland is the Data Analysis and Policy Planning Officer at the Alaska Mental Health Trust Authority. The trust graciously loaned us Heidi to AeHN and to the strategic roadmap process. She's really been the lead on this planning process over the past 5 or 6 months. And also due to the trust generosity, AeHN has benefited from the HIE expertise of Cedar Bridge Group, and specifically George Beckett, who has been our subject matter expert over these past months. If you haven't done so already, we would appreciate you completing your name and business affiliation in the chat box so that we know who is on the webinar. And the chat box can be found at the upper right-hand corner of your screen. Next slide. The federal government has been very interested in assisting states and regions with establishing secure ways in which health information could be transmitted among stakeholders. The state of Alaska was a recipient of funds to do this, and they decided the best way for Alaska to handle an HIE was to competitively procure a contractor to establish, implement, and manage the state's health information exchange. At this time, I'm going to invite folks who are on the lines to go ahead and mute your lines unless you are speaking, because we can hear some background noise from someone typing. And thanks for that. The Alaska eHealth Network participated in that competitive procurement and was ultimately selected. AeHN is a nonprofit organization governed by a board of directors composed of representatives listed in state statute by their constituency group or position. The current board members are pictured here. Me representing community providers, Jerry Jenkins also representing community providers, and he also represents Anchorage and Fairbanks Community Mental Health Services. Chris Emmon, who is the Director of Finance and Operations at Mat-Su Health Foundation. Beth Davidson is a representative of the State of Alaska, DHSS. Jennifer Darlene is a representative of the insurance industry and works for Primera. Dr. Erin MacArthur is a physician and works at Latouche Pediatrics. Dr. Timothy Ballard represents the Federal Healthcare Partnership and specifically the VA. Connie Beamer represents hospitals and is a project officer with AeHN. Stuart Ferguson represents the tribal health system and is at ANTHC. Dr. Sam Shirk represents the private providers, and he works at a Valdez Medical Clinic. Jan Harris represents the university and is at UAA. And finally, Jessica Oswald represents hospitals and is at Providence. Next slide, please. So the nonprofit AeHN has a small staff pictured here. And also along the right-hand side of this slide, you can see the key milestones are featured. Among those milestones are these very important dates that in June 2009, there was a law that was passed requiring DHSS to establish an HIE. In 2010, DHSS entered into that contract with AeHN. In December of 2010, we were the first state to implement direct secure messaging. And in 2011, we launched the HIE pilot. 2013, the AeHN the Alaska HIE goes live. Next slide. So finally, we are getting to the webinar objectives, and just wanted to review for you today that what we hope to accomplish is to share information and data with you, our stakeholders, and request your feedback. So you'll hear some updates about AeHN and the HIE, strategic options for both of them moving forward. We hope to answer some of your questions, and finally, request your input on what we've presented. Next slide. What is health information exchange? Well, with the right information available at the right time, individuals and caregivers can be active participants and partners in their health and the delivery of care. In reviewing this definition of health information exchange, we're reminded that this is both a noun and a verb. The noun HIE refers to the architecture of technology that makes the appropriate, secure, timely, and reliable exchange of health information possible. And the verb is, of course, what providers and practices want to accomplish to improve care. Next slide. So as I said, about 5 or 6 months ago, the AeHN board embarked upon a strategic planning process requiring significant review, exploration, research, discussion, and debate. The desired end result of this planning work is a roadmap for AeHN that will take us into 2022 and beyond. The board recognized the need for this deep dive as a result of many factors, including many in healthcare believe that the verb, health information exchange, and therefore the IT infrastructure, is a critical piece of a reformed and strengthened healthcare system. Also, the HIE was referred to in such a way during debate and discussion on Senate Bill 74 last session. That's the broad legislation addressing Medicaid reform. There was also a new decision by CMS to make high-tech funds available to build interfaces, and the state's success in applying for money to onboard up to 150 providers to the HIE. That is also going to make it possible to reach out to behavioral health providers and practices largely absent from the HIE to date. And then finally, there were some uncertainties related to performance and finances that needed to be responded to. Next slide. So the planning process started with a big effort in information gathering, and dozens of individuals representing stakeholder groups were interviewed. What came out of those conversations was a strong call to action from individuals like Dr. Ballard, really urging us to roll up our sleeves and look closely at what is happening with our HIE efforts in Alaska. Next slide. So the next couple of slides are reflections of what we heard from that information gathering stage. The current HIE participation in tools are insufficient and usage is low. The pace of onboarding is slow. Data from community providers and specialists is absent. What we need are centralized referral care management and analytics tools. That medications data is critical, and that reporting to the state remains cumbersome. Next, and then also that we needed to examine HIE within the context of statewide interoperability, that some networks within the state have made great strides while others remain siloed. There were some concerns about capacity and performance, and looking at a sustainability plan and pricing and thinking there were flaws there, and that the fee-for-service environment does not sufficiently incentivize HIE usage. Next. We also heard that there are questions about the best, most effective, and efficient way to accomplish statewide interoperability and the HIE, the verb. For example, and specifically, the Alaska Native Health Board requested the AeHN board investigate whether partnering with other states is viable. This could mean contracting with another state HIE for part of their functionality, contracting some expertise on Alaska projects, or completely merging with another HIE. The board has begun exploring this, and for all future options that are presented in this presentation today, the opportunities to partner are still on the table. we have learned that Alaska would be the first in these types of arrangements. Next. So I mentioned in an earlier slide that there were questions about performance. So we wanted to share some real numbers with you today. Onboarding by provider organizations. There are 63 organizations that have signed contracts with AeHN to date. 19 organizations are actively contributing data to the HIE portal. 16 are in the onboarding process. 82 provider organizations are in the outreach phase, with some having delays and barriers to include interface costs, EHR change, waiting for the hub or parent organization, and lacking specialist data. Some usage figures in the last 30 days, the provider and patient portals, you can see the use there. There are 730 user accounts, 298 unique user logins, 35 patient portal invites, and 12 patient logins. This is why the board is concerned. Next. And if you were to look at a glass half full, half empty analogy, this would be the glass half full view. This is a detailed listing of the participating organizations. And just a note on this that the list includes organizations contributing at a minimum admission, discharge, and transfer data to the HIE portal. There are other organizations that submit data to AeHN for public health reporting to DHSS. And the portal currently combines data from 11 different EHR systems, including Greenway, Prime Suite, NextGen, Allscripts, HealthFusion, Epic, Evident, RPMS, Cerner, MedHost, and Centricity GE. Next. So from the information gathering stage of the planning process, the AeHN board concluded that a new plan was needed. The trust graciously assisted us with Heidi's time and talents and the engagement of the subject matter experts Cedar Bridge Group. And the board has committed itself to hours and hours of work over the past 5 to 6 months and into the future. Next slide, please. And what we know now is that there are many strengths to build on at AeHN and with the HIE. You can see that there's, from this bullet list, there's an engaged and informed board, strategic mindset, and strong governance. And the HIE technology is in place, and data from 25 organizations are feeding a longitudinal health record for individuals. There are robust data sharing policies and protocols in place. There is some evidence that community readiness has shifted and that more organizations are ready to look at this. Behavioral health, and we have the first payer also involved. And a shift and a strength is that federal high-tech funds offer a pathway to needed resources. Next slide. So we've already covered a lot, and we expect you have some questions, but we are going to shift gears at this point and move into more detailed descriptions of the work of the past few months. And finally, if you're interested in the Alaska HIE enough to be participating in this call, we want to know your thoughts and get your feedback on the decision point that faces the AeHN board. We've identified 3 potential paths forward. You can see continue operating as is, expand the onboarding efforts, and number 3, expanding onboarding and services. So I'm going to hand this over to Ms. Heidi Wayland, who will walk us through each of these options and what they entail. Heidi?
Thank you, Nancy. Before I jump in, I'd like to start by just highlighting that the trust has a statutory responsibility to help ensure that Alaska has a comprehensive mental health program. And from the trust perspective, the term mental health program does not just apply to the services and supports for individuals with mental health needs. It really responds to the services and supports that are needed for the health and well-being of all of our beneficiary groups and Alaskans. Those are very much intertwined. And we know that a comprehensive integrated mental health program has to be supported by robust technology infrastructure. So we've viewed this planning process as a critical part of DHSS's and the Trust, and really our collective efforts as a community, along with the many other efforts that are underway in support of Medicaid redesign, to plan for a comprehensive program. And we know that without effective health information exchange, we will be very hard-pressed to provide whole person care and achieve the reforms that we are all working towards. And I can tell you that throughout this effort, we have struggled, the group working on this has struggled with the tension between health information exchange, the noun and the verb, and Nancy called attention to that in some of the earlier slides. And we know that there are many emerging technologies that could potentially replace in the future the need for health information exchange, the noun. And when I refer to that, what I'm really talking about is the aggregation of data into a single source to provide that comprehensive view of patient care across the system. But we also know that health information exchange, the noun, works. And those emerging technologies are not there yet to supplant the need for that consolidated view and to create that consolidated view. So in the discussions that we've had with our experts and with each other, we've seen health information exchange, the noun, as a really important stepping stone to support health information exchange, the verb, in Alaska for the foreseeable future. And it's really important to recognize that we have a very fragmented landscape. There are pockets of our landscape that have made great strides in exchanging health information amongst different organizations. And then there are other pockets that are still very siloed. I've also learned that health information exchange, the noun and the verb, won't happen unless we all work collectively to make it happen. So I think everyone, including patients, really need to be at the table as we're talking about how we're going to achieve interoperability, and we'll talk more about what that is in some of the subsequent slides. So the first option is really to continue as is, to keep the current staffing and technology the same, and to grow participation steadily. And we know there are some limits to the capacity of the current staffing, but the efforts that are underway in segments of the healthcare system, such as the tribal health organizations moving to a single electronic health record platform with Cerner, actually make the work of AeHN easier and faster. And this option has the advantage of using approximately the same level of funds. Basically, revenue would grow incrementally with participation. And we'd also like to see more attention to the engagement of key participants and communities of practice to encourage onboarding. So throughout its history, AeHN has worked to engage communities of providers, but it's really only taken hold in a handful of communities. And we'd like to see more of that, more of groups of organizations coming together collectively and deciding to kind of integrate their data through the health information exchange. So what does this really mean? I'd like to give you a brief overview of AeHN's current services. First, AeHN supports more than 4,000 direct secure messaging users that collectively submit more than 60,000 messages each month. And AeHN also maintains a provider directory to support that function. Second, AeHN maintains a longitudinal health record, and that's, I think, what we typically think of when we think about HIE, the noun. Longitudinal means over time and across settings, and it's really about moving from encounter-based or provider-based records to the patient experience.
You know,
the records that reflect the patient experience.
Refers to
and this
the
is
plan, the payer?
critical to whole person care. And I'd just like to remind everyone that if you are online, please hit your mute buttons. We're trying to do that here, but we're getting a little bit of noise. Thank you. And I would also like to say, if you have questions,
plan, the payer or the finance?
Feel free to use your chat box and submit those electronically throughout the webinar. So the longitudinal health record service has active patient identity reconciliation, which is really what allows you to merge the records. And then there are two portals, one for provider organizations, for users within provider organizations, and the other for patients. AeHN also is connected to the National eHealth Exchange, which creates a query option that has access to records from other health information exchanges across the United States that are connected to the query, and also in the future has the Veterans Administration data as well as the Department of Defense data. The Veterans Administration nationally was connected and is currently in testing again after a few changes, but those are obviously very important data sets for Alaskan providers. And AeHN also provides a service to the Department of Health and Social Services with public health reporting, including syndromic surveillance, as well as certified solutions to meet meaningful use. So for example, there are some provider organizations that use the patient portal to achieve their meaningful use objectives. And finally, and interestingly, a relatively new service for AeHN is an outbound clinical data feed based on eligibility. Premera sends AeHN its eligibility data. AeHN matches it and sends back clinical data from the admission, discharge, and transfer files. And Premera's clinical team actually uses that data to track admits and discharges to manage care and offer support programs to their patients. And for Premera, this is actually standard protocol in other states, and this is the first time that they've been able to get this data in Alaska. And I think that gives us kind of a window into how others might be able to use this data as well. Next slide, please. So what we're showing here is an actual view of the provider portal. So if you were a staff person at a provider organization and you were logging in, here we see some test data from a patient named Yvonne Wilshire. This is the view that you would see on the summary page. You would see diagnoses that are brought in from the admission, discharge, and transfer ADT files. You might see allergies or adverse reactions that would come in from the continuity of care documents or the ADT files. You could configure alerts when, for example, patients are admitted to a certain type of service. And then, of course, you see the encounter history, and this is really critical. This is that patient experience, the history of individuals across different settings. And finally, you would see medications data compiled. And today, the continuity of care files are the source for this data, but we know that users are demanding a more comprehensive strategic approach to medications data. Having access to as comprehensive a medications data set on the pharmacy side, if possible, is really, really critical, and is one of the things that we have been looking at. Next slide, please. So, of course, the crux of the health information exchange is bringing together health records from across organizations. And you can imagine that a huge part of this effort is associated with the process of mapping the fields from each provider organization into a standard format so that the data can be viewed in a meaningful way across organizations. For example, the same data element in one electronic health record could be referred to very differently in another electronic health record. And so when an organization is undertaking the process of onboarding to the health information exchange, that's a good chunk of the work that's happening alongside the technical work of actually developing that interface so that, for example, when an individual is admitted to the emergency department, that admission shows up in the health information exchange within about 5 minutes of entrance. It's pretty cool. Next slide, please. So things to consider when we look at option one, which again is kind of continuing on the current path, is that there are some significant upsides. We don't anticipate that it would cost significantly more to operate, and the focus would really remain on tapping the existing and core HIE functionality and services that are in place today. But it also relies on providers continuing to onboard, and we've seen that onboarding occurring at a relatively slow pace, a slower pace than was originally anticipated. Another potential downside of this is that it does not take advantage of the federal funds that are available for interface costs. And we have certainly heard that the cost of developing the interface in order to onboard to the HIE has been a barrier to participation for some. So, you know, in short, we think this has a relatively low risk, but also potentially a low return, because we know that there are organizations out there that are saying these services are not of value to us. We're not getting enough value from it. So this really relies on organizations continuing to participate, and their participation and the data that comes from those organizations driving up the value of the HIE. We know that AeHN struggles with sustainability now, and we do have concerns that they would continue to struggle if organizations don't see the value and move towards adoption, both in onboarding, but also then in using, which I think is where we're seeing a gap today. Next slide, please. Option 2 looks at really trying to expand onboarding efforts and leveraging federal funding that was secured in October 2016 by the Department of Health and Social Services from the Centers of Medicare and Medicaid Services to build interfaces for about 150 organizations to onboard to the Health Information Exchange. And this would include behavioral health providers, as well as about 100 tribal and non-tribal organizations that have been identified by the Department of Health and Social Services under the Enhanced Tribal FMAP or Care Coordination Agreement project that is outlined in SB 74. And it would also include developing an interface with the Division of Behavioral Health in order to be able to transfer the minimum data set for behavioral health organizations who are using an electronic health record and today double data entering that minimum data set into AeHN. And this is part of the Division of Behavioral Health's efforts to streamline the process of submitting data to the division. In addition, they're looking at reducing the number of fields necessary for the minimum data set. This particular facet of the project is where the trust invested the match funding in order to secure these federal funds as part of the trust's overall investment of $10 million over the next 3 years into Medicaid redesign that the trustees made last spring. And this option really focuses on about a 2 to 3 year time horizon. So again, really using the core existing functionality and tools and increasing AeHN's ability to onboard by targeting 150 organizations and paying for, helping to pay for the interface costs. Next slide, please. And we wanted to give you a little bit of background about this federal funding opportunity. HITECH stands for Health Information Technology for Economic and Clinical Health Act. And this was an act that was enacted under Title 13 of the American Recovery and Reinvestment Act of 2009. So it is not part of the Affordable Care Act, which is notable at this moment in time. This act really was the driver for the Meaningful Use and EHR Incentive Program. And it also set aside funds for health information technology infrastructure projects that would support eligible providers in that program in meeting meaningful use, and that includes health information exchange technology. And in February of 2016, so a little more than a year ago, the Centers for Medicare and Medicaid Services issued a letter to directors that expanded the use of these funds, these high-tech funds, to include the cost of building interfaces to health information exchanges for providers that were not eligible for meaningful use. That means behavioral health organizations and correctional facilities, as well as other possible providers in our healthcare system. So as you can imagine, when this letter came out, the Trust and the Department of Health and Social Services, the Division of Behavioral Health, were very eager to take advantage of this new funding stream because we had previously been looking at how to cover the cost of onboarding behavioral health, and this really provided a vehicle for that. So Alaska became one of the first states to request and receive approval for funding under this expanded guidance. Next slide, please. So option 2, really dramatically increases HIE participation over the next couple of years by providing that funding mechanism that allows AeHN to increase its capacity to onboard and also reduces costs as a barrier to onboarding by providing funds to pay for a good chunk of the interface costs associated with onboarding. I think this option also really improves the ability to integrate behavioral health and primary care within our healthcare system. And I know many behavioral health organizations who are eager to participate in the Health Information Exchange. And the benefits to them of not having to enter the minimum data set into AeHN are huge, but the real advantage is improving their access to information about care that is happening in other parts of the system. And that, of course, is critical both to behavioral health and primary care integration, but also to our system's ability to move away from crisis care. And this option would also may also support reconciliation for the Department of Health and Social Services efforts to secure increased FMAP funds as part of the tribal FMAP project under SB 74. And I say may because there may be other options that would be quicker to deploy that could support this need, and more analysis is needed to really figure out what's the best way to meet this need of being able to identify individuals who are Alaska Native and served in a tribal health organization who are then referred outside of the system in order to recoup the full FMAP that's possible for that encounter. Next slide. It's also important to note that we do not believe that this would increase costs to existing participants, and it would provide funds for AeHN to resolve some of the staffing challenges to really be able to increase capacity to onboard smoothly. There have been a number of drivers for the slow pace of onboarding to the Health Information Exchange to date, and they can quite frankly be a little difficult to disentangle, but certainly staffing constraints is one of them. And it would also dramatically increase the value of the data that is in the Health Information Exchange, but it doesn't add new services. And it doesn't really provide the funding to be able to investigate and pursue services that would be of value and might make sense in that central function. And we also think that AeHN's financial health would remain uncertain, and we can talk a little bit about that more, but it would really require a momentum. Option 2 is based on the idea that a momentum will be built towards the Health Information Exchange that would then attract others to onboard. And it would give AeHN the opportunity to demonstrate its capacity to onboard at a pace that is, quite frankly, much higher than what has happened in the past. Thank you. Next slide. So the third option really looks at expanding onboarding. So that means pursuing the enhanced onboarding efforts already described in option 2, the $5.3 million that has been secured in high-tech funding for the 150 providers, as well as pursuing additional federal funding to cover the existing operational expenses, both the staffing and technology that AeHN currently incurs, and the staffing and technology necessary to deploy new services that would increase value to participants. This option also includes really having AeHN embrace that role of convener for interoperability. And we will talk a little bit more about what that means. But what we know is that AeHN cannot be exclusively focused on Health Information Exchange the now. We need to be focused on how in Alaska are we going to achieve interoperability, and how does that change as emerging technologies come online? How can we do it in the most efficient way from a user perspective in terms of integrating new processes into workflows, but also from a cost perspective to the state as a whole. And when we are looking at this option, we're really looking at a 5-year time horizon. Next slide, please. So I want to bring you back to the HITECH Act funding that we talked about before. And when the letter came out in February of 2016, as I mentioned, it was clear that the funds could be used for far more than they could be in the past, and that it presents an opportunity to Alaska. But what we did not understand until we undertook this process, and we learned from our technical assistance contractor, Cedar Bridge Group, is that these high-tech funds could actually be used for much more than building interfaces to the Health Information Exchange. They could be used to support existing staffing and technology costs, as well as additional staffing, technology, and deployment costs. So these funds are really available to Health Information Exchange efforts in order to, until they have built mature health information exchanges. And states across the nation are looking at this and looking at how can they use high-tech funds to help really develop a mature and high-value health information exchange in their states. As part of this effort, we asked Cedar Bridge Group to help us understand this opportunity from a financial standpoint. And by leveraging high-tech funds and repurposing the current fees that the Department of Health and Social Services pays to AeHN for its participation, the state, using those fees as state match for high-tech funds, so it's basically a 90-10 split, 90% federal funding to a 10% local funding, could bring an additional $21 million in revenue to support our effort to develop a mature HIE in the next 5-year period through federal fiscal year 2021. Next slide, please. So one of the things that we were encouraged to look at very early in this process was the question of interoperability. What does statewide interoperability look like? What's our vision for statewide interoperability? And what is the role of the Health Information Exchange within that vision? And one of the things that we did is to really look nationally at what is happening in the area of interoperability. And I'd like to start by just describing what interoperability is. And in a very basic definition, interoperability is the ability of a system to exchange and use health information from other systems without special effort on the part of the user. So when we're talking about interoperability, it's really the ability to exchange and use data from other organizations or systems without tremendous effort, having to log into multiple different systems, et cetera. And an interoperable healthcare system is essential to supporting value-based care. So for example, combining administrative and clinical data is one of the key things that has to happen in order to enable value-based payments. And really, value-based care can be seen as a driver for health information exchange because it is essentially a prerequisite to being able to do that. Interoperability is also an enabler of a learning health system. And in the national roadmap for interoperability, what you see is that interoperability is a path to creating a health system that can learn, where individuals are at the center of their care, providers have seamless and secure access to health information from many different sources. Health information is portrayed in a longitudinal picture, so you see that patient experience rather than episodes of care. And public health agencies and others can rapidly learn and develop treatments or preventative programs that can really impact the health of a population. So this slide is really trying to take a step back and say, HITECH is a funding source to support nationwide interoperability. And within Alaska, we do feel it's very important for us to be thinking about interoperability, and then health information exchange is one of the vehicles under that. Next slide, please. So one of the exercises that the AeHN board overtook was to identify the issues that were facing Alaska, the interoperability issues facing Alaska. So we spent an afternoon identifying all of the issues that we saw impeding Alaska's ability to be interoperable across organizations. And these are the top 5 issues that were identified. The first is the ability of behavioral health and other specialty providers to exchange data with other segments of the healthcare system. The second is having centralized tools for care coordination. We know that is a growing need in our healthcare system. And those centralized tools would include support for referrals and panel management and access to clinical records across the system. A third issue that we identified is the lack of coordination around statewide interoperability. Right now, there is not a forum to discuss and plan for statewide interoperability and to make sure that we are complementing each other's efforts and not competing with them. We also talked about the importance of data standardization and really making sure that the data that comes into a system is meaningful and can then be used in analytics. And we talked about the need to continue to focus on streamlining state reporting, not just public health reporting, but also reporting to the Office of Children's Services or the Division of Behavioral Health or Senior and Disability Services. How can we get smarter about the way in which we exchange information for all sorts of different purposes? So what we did is we were examining, next slide please, this option was to test how would we use the additional revenue that we could get from the HITECH Act. And we aligned the priorities that AeHN would pursue with the interoperability needs that we saw in the system. And so what you see on this slide is basically an exercise that we undertook to map what we saw as the shared needs with a heavy emphasis on payer needs, which we know are going to more and more be everyone's needs as we move towards value-based care, to HIE priorities. So for example, we know we need improved transitions of care. Can AeHN offer tools to support closed-loop referrals? So the referral goes out from an organization along with all the justification for the referral. An individual, a care manager, for instance, is able to see the status of scheduling and of actually seeing the patient, and that loop is ultimately closed with all the documentation necessary to finalize the referral and get the information back to the provider. I spoke with one doctor who said even when they make the referral and they have staff who call and follow up to get the records, sometimes they're not able to get access to the records. They're not able to demonstrate that they were the ones that made the referral. So it can be extremely costly to really close the loop on referrals that are made today. And in Dr. Ballard's quote from the beginning of the presentation, this was a part of what he was talking about, the cost to the Veterans Administration and the Department of Defense when they send somebody out of the system, the cost of trying to find the current status and get the clinical documentation back and associate it with their record. So that's just one example. Another example is preventing unnecessary 30-day admissions. And we've seen ASHNA take the lead on a very important project to implement EDI, which is an application that kind of sits within the emergency department technology suite and provides very easy to use alerting and information that's tailored to the emergency physician's needs. And so one question and one project that we have costed out as a possibility under this expanded option 3 is really looking at how to integrate with the EDI initiative and looking beyond the circle of emergency department physicians who would use that current application to the next line of providers who might need that information and be able to integrate into that process flow. So I just wanted to give you kind of a taste of how AeHN has been analyzing option 3 and how the opportunity for additional revenue could lead to very strategic services with immediate value being deployed. Next slide, please. This option is not an easy option. And there are, the effort to onboard alone is a significant lift. Onboarding 150 organizations in the next 2 or 3 years would be a major lift. And then here we're talking about really examining the technology and services and tailoring them to meet the immediate needs of customers, which is another big lift. And we know that option 3, and really probably all of the options, are going to require AeHN to take a fundamental look at their current sustainability plan. So what you're seeing is the original model for sustainability that was developed at the kind of beginning of the health information exchange. And the idea was that with an initial approximately $10 million investment, AeHN would move into an operating mode that would be supported originally at its current levels, about $2 million a year, and that cost would be split in 3 ways: 1/3 with the Department of Health and Social Services, 1/3 with hospitals, and 1/3 with community providers. And what I think we are seeing and hearing with this feedback is that the initial investment has been insufficient to really create a strong suite of valuable services and propel adoption in and of itself. And we've also seen that there have been a lot of barriers to participation, and not excluding market forces. When you're in a fee-for-service environment, that's not necessarily driving individuals or organizations to participate in the health information exchange. This sustainability model has also placed a tremendous amount of burden on the Department of Health and Social Services and hospitals, who are really the predominant users today, to carry the costs of the health information exchange, while community providers trickle on. And finally, I think this plan, the original model, really overlooks the important role of payers. The data that is in the health information exchange is really critical to payers, who often have to rely on claims data when clinical data can give data, that's not months old, but rather, hours or days old, that they can use to support their clients. Next slide, please. So through this process, we've also been rethinking sustainability. And in option 3, the sustainability model includes leveraging high-tech funds to subsidize interface costs and increase the value of the HIE. So basically, leveraging high-tech funds to develop a mature HIE, statewide HIE in Alaska. It also includes engaging payers to provide the leadership and the financial contribution necessary to really promote the adoption and also to help sustain the HIE. And an example of this in other states is that, payers have a strong incentive to have provider organizations using the health information exchange. So they may be very creative in how they incentivize provider organizations to do that. The point is that we need payers to be on this team, helping to drive usage and helping to really realize the full potential of the HIE. And then finally, really looking at how the services that AeHN pursues and offers need to be very tightly tied to stakeholder needs and to projects or services, tools that they're willing to adopt and that they see value in paying for. So on the pie chart that you see on this screen, you see a bigger capital investment, and this is, kind of approximate dollars, but, you could envision investing a good chunk more into the organization over the next 5 years while High-Tech Act is in place, and you can use the existing monies that are already being spent on HIE in Alaska. You can leverage that with federal funds, and really attracting and recognizing that there's a much broader set of stakeholders who have a strong stake and may come to the table to participate in the HIE in the future. Next slide, please. So we have a couple of slides that talk about considerations for option 3, and then I'm going to hand it back over to Nancy. So option 3, like I said before, it is not an easy lift. It would be a very ambitious effort to increase the value of the health information exchange and it would tap federal funding for the additional needed resources with no additional cost to participants. And in the analysis that we've done on this option, we've estimated that the operational cost of AeHN would be about 50 to 60% higher than they currently are. So currently, the operational costs of AeHN are about $2 million a year, and we have estimated that by increasing the participation and the services that AeHN offers, and really having a strong bench and addressing some of the issues, staffing shortages that are in place today, the budget would probably run about $3.2 million a year. And the anticipated increase for that would be covered by bringing more stakeholders to the table and really focusing on the essential partnership that AeHN needs to have with payers. Next slide, please. And as I mentioned, this would allow AeHN to acquire the staff and the technology expertise necessary to deliver services in the very near future that have immediate value to participants. So, for example, this could help pay for more technology resources, subject matter experts, technical assistance, in order to really make sure that AeHN is a cutting-edge health information exchange that's tightly interwoven with the interoperability approach that Alaska is taking. Now, in order to be successful, AeHN would be on the hook for creating value that really far exceeds the cost of sustaining this centralized option. And in order to do that, AeHN has to embrace the role of being the convener for interoperability in Alaska. And AeHN has to be willing to adapt if and when emerging technologies would supplant the need for a health information exchange in the future. And I am going to hand it back to the presentation back to Nancy now, and then we are going to have time to answer all of your questions. And I see some have begun submitting questions, and please, if others have questions, please send your chat. You can select send chat to everyone so everyone can see it, and we're receiving some that are just here on our side. So Nancy?
All right, great. Thanks so much, Heidi. So this slide really takes us to where we are presently. The AeHN Board of Directors has a meeting on April 10th where we'll be weighing out these three options and all their considerations. What we hope is that you'll take advantage of your stakeholder representative on the board, and you'll let them know so that they can then convey that to the rest of the body, what your thoughts and feedback is. And then moving forward, we'll continue to update stakeholders as we define the path forward. We think that this has that there's real value, and it's very important for the board and the organization of AeHN to continue communicating frequently with stakeholders, and because things do move fairly fast in this technology world and healthcare world, we'll be doing that on a more frequent basis. The last slide of this presentation gives contact information for each of the board members, and you're welcome, of course, to reach out to any of us, and if you feel most comfortable reaching out to your stakeholder representative, feel free to do that. And that's all I have. So Heidi, do you have any questions in the chat box?
We do. We have a couple of questions, and we have time, so please, if you have questions, feel free to send us a chat. The first question states, you have discussed minimum data set input for AeHN, and we use AeHN totally. How will that affect us with this additional program? So for those of you that use AeHN, you will continue to use AeHN. And the Division of Behavioral Health has secured funding through the HITECH Act in this last round of proposals to actually connect AeHN and the Health Information Exchange. So there may be that option in the future, but the advantage with the minimum data set is really for those organizations who are not using AeHN as their electronic health record. Instead, they would develop an interface with the Health Information Exchange, and that minimum data set would be automatically transferred for them to the Division of Behavioral Health. And I hope that answers the question. We have one other question that's related to behavioral health, and it is, how within behavioral health and AeHN being separate from our hospital electronic records, will this be combined when our behavioral health clients do not want any of their information on the medical side? That's also a really good question and a very important question. Currently, AeHN deploys consent policies that meet HIPAA guidelines and 42 CFR. And with the integration of behavioral health organizations and patient data into the Health Information Exchange, there are additional protocols that would be put in place specifically for services that are related to substance use disorders. Currently, AeHN uses an opt-out model. That means that if an individual wishes to not have their data on the Health Information Exchange, they need to specifically opt out of that, and they can do that within their consent policies and forms that they fill out when they see a provider. For individuals who are receiving substance use disorder services, they would actually have to opt in order for those services to be viewable within the Health Information Exchange. And again, just to be clear, where that information would be combined is in that centralized Health Information Exchange that AeHN supports through the provider portal and the patient portal. Other questions?
Do you have any other questions in the chat box?
We do not have any at this time.
We anticipated we'd have a few questions, so we made time at the end here. So it's a good opportunity to ask anything you're particularly curious about. Questions, concerns, issues, suggestions? So obviously everybody's really busy, and so we don't want to keep you online just to keep you. So if there really aren't any other questions, then we wanted to tell you how much we appreciate you joining our webinar today, how much we truly appreciate your commitment to AeHN and having your board representative on the AeHN board and spending so much time on the strategic planning process. And remember that this is not your only opportunity to provide feedback and thoughts, and that any of the board representatives would be happy to visit with you and reflect your thoughts and comments to the rest of the board. On that note, Heidi, do you have anything else?
Nope, just a huge thank you to everyone who participated and encouragement to connect with your representative on the board. These are really important issues and very difficult decisions, and this needs to be a community-wide collective movement. So thank you again for participating today, and I look forward to hearing your input, and I'd like to commend the AeHN board and staff for all of the work that they have done.
All right. Well, thank you, everybody, and have a good afternoon. Bye-bye.